Okay, so today we will discuss some scenarios related to pediatrics. So usually, uh, because not every time they will be asking the physiological, pharmacological, and anatomical changes in pediatrics. Okay, so they will be just putting a scenario, for example, that there is a 4-year old baby with the Down syndrome. Okay, and it's presenting for adenotonsillectomy. Okay, so for example, this is one of the scenario, or like 10 years or 8 years old CP child for gastrostomy tube. Okay, so when we are considering this scenario, what do you think, what will be the concerns with reference to pediatric patient? Yes, Zishan.
Sir, concern relating to pediatric patient with all the pharmacological, anatomical, and physiological differences from adult would alter my anesthesia in the form of difficult airway, early desaturation, and difficult cannulation, fixed cardiac output, uh, early bradycardia, increased chances of respiration.
Early
Uh,
bradycardia, what do you mean by early
uh,
bradycardia?
Not early bradycardia, sir. Uh, Fixed cardiac output and more prone to bradycardia, sir. Prone to bradycardia.
No, it's not prone to bradycardia. Think cardiac output is dependent on heart rate.
Cardiac,
So if
yes, sir. Heart rate dependent cardiac
so,
output.
there is high vagal tone. Okay, so
Yes, sir.
anything which will increase the vagal tone, it can cause bradycardia, and bradycardia will not be tolerated because the cardiac output is dependent on heart rate. Okay, what is the other denominator?
Yes.
What is the other thing in cardiac output? Heart rate versus
Uh, it was systemic vascular resistance.
Stroke volume.
stroke volume. Okay, so stroke volume and heart rate. Usually in adults, stroke volume will be adjusted by this will be adjusted through what will be the factors? Physiology, but just have a quick revision. How
Contractility, sir.
stroke volume, one thing
Contractility
is
of
contractility. What else?
preload, sir.
Very good. Okay. So preload and afterload. So these three things will determine stroke volume. So the more contractility, the more stroke volume, adequate preload, good stroke volume. Afterload, if it is not too high, like all the afterload in the form of SVR, it has less effect, but stroke volume is dependent on all three things. Okay, so that is, so try to use the correct words. So
Yes,
one,
sir.
and if you can just organize the answer in a better way, that pediatric patient, there are consent issues. Okay, anxiolysis, IV lines. Okay, then
Yes.
equipment, drug dosage and dilutions. Okay, what else? IV with reference to that. So maybe we need inhalational induction, anticipated difficult airway because of what are the reason for
It could be due
anticipated?
to
Yes.
sir. There are because their anatomies are different, so it could be uh, uh, short neck, high arch palate, enlarged tonsils, large tongue, and inadequate mouth opening. And also the cricoid, so the tube passing, it can also be difficult as cricoid is the narrowest part. So even if you pass the glottis, so tube can still be stuck on
What is physiologically difficult airway?
the physiological difficult airway is that airway in which uh, it gives us little time to obtain intubation and
So
patient
not only
desaturate
not
clearly.
only the anatomical problems, here there is physiologically difficult airway because
Yes.
there is
So
less
because children, yes,
yes,
sir,
speak out,
children
speak out.
have less FRC, we don't have the time to be. The
And
children go hypoxically.
oxygen consumption is more. Okay,
Yes, sir.
so you have less saving and you have more expenditure. Okay, and then so not only try to speak out on Zishan a little better. What do you mean by large this palate? What you say, high arch palate?
Yes, sir.
What does it mean?
Sir, high. Uh, it means that the upper heart palate is curved, so our blade, uh, one of the factor of difficult intubation,
Okay,
sir, this high
so
arch palate.
when you tell these things and then you say difficulty in mouth opening, it's not difficulty in mouth opening, small mouth. Usually, of course, their
Small
mouth
mouse.
is small, so it's not
Yes,
opening in or difficulty in mouth opening. Okay,
yes, sir.
so anterior larynx you did not send. This is the most important thing.
Yes.
Anterior larynx, then this large tongue, large head. Okay, the intubating position is a little difficult to make. Which laryngoscope we use? Straight blade.
Straight blade.
Okay, and then as you tell that difficult to, of course, we have formulas and everything. Difficult to predict endotracheal tube size accurately. Okay, so that's why we have to carefully choose between cuff versus uncuffed. And even if the tube passes through the glottis, the cricoid is because it is funnel shaped. So cricoid area is the narrowest part. Okay, so that will be the narrowest part and tube can stuck over there. So this is like in this you have to make a summary. If they are asking you in detail, that's something else. But usually you don't have time to speak so much. So pick the most important and arrange them in an order that you are not able to miss you don't miss anything. Okay. So another thing. So if you summarize, difficult airway, heart rate dependent cardiac output. Okay. Equipment challenges. Okay, and uh, risk of hypothermia. Uh, so not only equipment, you can also put the same here, drugs. You have to carefully calculate the doses. You have to use appropriate size syringes and dilution, and there are chances of error. So it should be carefully managed, and then like you might face difficult, challenging cannulations. So we have vein visualizer, and ultrasound even is difficult to use in pediatrics because ultrasound. What is the name of the probe which we can use for pediatrics?
Hockey probe.
Sorry, hockey,
Hockey, sir. Hockey probe.
hockey stick. Okay, so okay. So, this person, Omar, you are also exam candidate? Any other exam candidate,
Yes,
please?
yes, sir. I'm also exam candidate.
Okay, so please try to do you to take you can also, because the priority is for the people who are appearing in the exam. Okay, so
Okay, sir.
I hope you understand, because the what's the significance of this thing, that pediatric scenario will be there in all. There is will be no exam in which pediatric scenarios are not being asked. Okay, so you have to just give me a second. Okay, so you have to make a 30 seconds to 1 minute answer in which you summarize everything, so that if they want to make some more details, they can ask you. Otherwise, the basic thing you should not miss. Okay, the basic things you should not miss in your answer. Okay, so what other challenges you can have, like for example, if you just think about blood volume. So you have to carefully, because usually estimating blood loss will be a challenge. Whatever surgery it is, you have to carefully, because their blood volume will be a little higher, so around 80 to 85, maybe up to according to age, of course. So you have to carefully calculate the blood volume and the allowable blood loss, and you have to carefully look at the blood loss, because maybe some blood loss which is not significant in adult may become very significant in pediatric. Okay, so this is how, by the way, how you estimate the blood loss. Yes, Dr. Umar, you can tell.
Yes, sir. We can calculate it by knowing the HCT. The formula is estimate blood volume multiplied by HCT initial minus HCT final
No, no.
divided by HCT initial.
That's a formula for allowable blood loss. My question was estimation.
Estimation, sir, we can multiply it according to the age.
No, 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 no,
If
no.
the child age is,
You are
let
you are
us,
not
sorry,
understanding
sir,
my question.
65 yes,
No,
sir.
no, no, no. You are not understanding my question. Estimation of blood loss. I'm not telling
Estimation of
estimation of blood
blood
volume. I've
loss.
told already. Estimation of blood loss. This is general question. This is for everywhere. Surgical field.
Sorry, sir,
Then
I just know the allowable blood loss
no, 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 not allowable. So,
estimation.
sir, so blood loss. I'm sorry, because I did not write clearly. So, surgical field, gauzes, drains,
Okay, sir.
okay, because usually there will be some clinical effects of the blood loss, but here these will be not very accurate. Right? Usually there is tachycardia and hypotension. Here, maybe these things will not appear very clearly. Okay, so. So sometimes it's difficult, and you should be knowing, usually if it is large pack, so in adult things will be different. For pediatrics, it's very difficult to estimate. Anything else, Zishan, in blood estimation? So surgical field, gauzes, drains, clinical parameters.
Section, sir.
Sorry. Oh, that drain. That is drain.
Drain, yes, sir.
Suction drain. Okay. And then if you have some other parameter, like stroke volume variation. Okay. So that will tell you uh, it can indirectly guide you about the blood loss. Okay,
Sir,
And
so
sir,
these
then we
factors
have
are also in the adult
yeah,
case.
these are also in adult. These are the same.
Okay, sir.
Okay, like you
Yes,
have
sir.
to look if they ask you, because this you can tell. Maybe this is something you should know, and if they ask, you can tell. Okay, so estimation of blood loss is very important, because this will tell you the like when you will give, because blood this allowable blood loss is one thing, blood loss is one thing, and then what are blood conservation strategies. Okay, I know that we are getting a little off topic, but let's finish this topic. What are different blood conservation strategies why we can minimize the blood loss?
Well, there are different hours starting from basics. The surgeon could start a minimal invasive surgery in which there is less blood loss. Then
Very good.
use of tourniquets, keeping the blood pressure in the normal range, not normal range,
Hypertensive.
not allowing, yes, not hypertensive.
And
Uh, then we have some drugs available in the form of tranexamic acids, uh,
positional.
position,
Positional.
positional.
Okay. So avoid congestion or in any position which can cause avoid positional strategies which avoid congestion. Okay. What else?
Yes, sir.
Then you can give some medication like tranexamic acid. What else? Salsaver.
Saver. Yes, sir.
Okay. So these are certain things, common things, and then hemodilution. Okay. So hemodilution will decrease the effect the per unit blood loss. Okay. Of red cells. So 1 ml will have lesser blood volume going on. So these are few things. So in pediatric, of course, all these effects will be more. You have to be more careful. Okay.
And sir, we
The
can say hypothermia, avoidance of hypothermia. Yes,
Yes, yeah,
hypothermia can.
actually, yes, there are so many other things like anything which is causing the platelet dysfunction. Okay, and like there are this careful technique, the careful surgical technique. Hypothermia is very important. Okay, because it will cause platelet dysfunction. Okay, so these few things like okay, so how to challenge the angiolysis? What are different ways to give angiolysis in pediatric patient? Repo building. Okay. Internationally, there are some mock mock operation rooms. You can just maintain otherwise just repo building and then uh, oral versus intramuscular versus intranasal. You can use midazolam. You can use dexmedetomidine. Okay. Ketamine. So different options you can use. Fentanyl, intranasal lollipops. These are the things you can use for sedation and anxiolysis. Okay. Then appropriate size, BP cuff, appropriate size. Try to use minimum syringes is better than 5 cc and better than 10 cc. Okay. So, like more bigger syringe, you will generate more pressure. So it can even create problem in it can uh, create problem in the cannula as well. Okay. Drug can extravasate if you are using more a bigger syringe. So force per unit area. So pressure, there will be more pressure. So more area, more pressure. So it can also create problems. So it's always better to use smaller size syringes. Okay. Uh, okay. Monitoring problem, fluid problem, anxiolysis, consent issues means that who will give the consent. So it's a separate topic. It's not commonly asked in our exams, but you should be knowing that who is the legal guardian. Who legal guardian means there is a paper. Otherwise, father or mother can give the consent. Because this is more so in West, where there are some other issues as well, single parent, and there are so many things other than that. So consent issues you can just mention in your list and the rest of the things that you have to because there are more chances of vagal reflexes. Okay, and vagal reflexes can cause severe bradycardia, and bradycardia will not be tolerated. But usually, the more cardiac arrest, causes of cardiac arrest, there are more chances to be because of respiratory cause rather than cardiac causes. Usually, the respiratory causes are predominant in pediatrics. Okay, so okay, so there will be difference in this pediatric advanced life support neonatal resuscitation program. We will try to cover in complications scenarios. So usually these are the common things which you should be knowing. Let's have a look. In the shivering mechanism is not there, so they generate uh, the heat production is through non-shivering thrombogenesis. So that's what we were discussing. Okay. Prominent occiput, large hair, tongue is elevated. This anterior larynx. Okay. And it is if there is only because the airway is very narrow. So if even small bit of secretions come, it can cause obstruction. So this is the things. I will just have a look if I missed anything. Respiratory reserves are there. This FRC is one of the reason is the bucket handle movement and this the respiratory mechanics are not fully developed. So FRC is low and um, obstruction can occur. Oxygen consumption is more. Okay, so you see the work of respiration may be 50% more of oxygen consumption. Alveoli are thick walled. They can and then, if it is, yes, there is another concept of because neonates is a separate topic. We will discuss separately, inshallah. Uh, Maybe I need to take more than one session for pediatric. But usually, there are chances of postoperative apnea if the post gestation, if it is premature babies. Okay. So in the cardiovascular system, we discussed. Heart rate dependent, vagal sympathetic tone is dominant, which I was telling you. Okay. So bradycardia will not be tolerated. And you should be knowing the normal ranges. A rough idea you should be knowing. There is a formula, I don't remember, but you should know if you can. There is a formula of calculating the estimated blood pressure. Maybe I remember when I did PL PALS, it was written somewhere. So you should be knowing the estimated this one. Okay. Blood pressure formula, estimated systolic blood pressure. Okay. PDA can be there for some time. As I was mentioning, newborn 85 to 90, and gradually with up to puberty, it will become around 70 to 75. Okay. Kidneys are not fully developed, so they don't have the concentrating ability. So they are sodium losers. Okay. So they can become hyponatremic. So that's why the concept of fluid before there was a terrible solution which they used to have, which is called PEDS solution, which is 10% dextrose with 0.18% normal saline, which is called as a killer solution. Okay. So it's always better to give high isotonic solutions like lactated ringer lactate, or even normal saline is a better choice than this like dextrosaline. And if any patient who is at risk of hypoglycemia, you will replace the dextrose separately. So that's a separate thing. And don't mix these things, because if you are giving more dextrose, it is also you can say it's sort of diuretic. So that will even uh, already prone patients for dehydration. So you have to maintain a urine output. Hepatic function is not fully developed. So there may be initial doses will be more because of high volume of distribution, but subsequent doses you have to reduce. So this, you can just make your answer summarizing all these changes. So actually, I did not mention in my initial I missed about this renal and liver. So initial doses will be more because of high volume of distribution, and because of poor liver metabolism, the subsequent doses may be reduced. Okay. Uh, Hemoglobin F levels are there, so 3 DPG. So yes, they can ask you about this thing as well. A brown fat, which is located in small amounts around scapula, mediastinum, kidneys, and adrenal, which is for non-shivering thermogenesis. Okay. It comprises 2 to 6% of neonatal body weight. More oxygen is required for the metabolism of these brown fat stores. Heat loss during anesthesia is mostly by radiation, but also be lost by conduction, convection, and evaporation. This is another topic: how to have heat loss during the anesthesia. Optimal ambient temperature to prevent heat loss is 34 degrees centigrade, but actually, practically, we never achieve these temperatures in the operation theater. So, but you have to just, if you are using bear hugger, you are covering the patient properly, and you are using warm fluids, you can prevent. Okay. So, if there is hypothermia, as Ishan was also mentioning, more chances of bleeding, the drug metabolism will become more slow, the recovery will be slower. Okay. Uh, so neonates will have high requirement of, and sorry, premature baby will have less MAC, and gradually neonates will have relatively more, and then it goes down up to adult. Okay. This one. Am I telling the right about the MAC? Yes, Ishan or Umar, Dr. Umar.
Yes, sir. Mac.
Yes, sir, but
Yes,
there is
Mac.
a difference between the SIVO MAC.
Okay, what's that?
Sir, Dr. Zishan, tell me, I don't remember it. No, sir. The pattern is that in the new infants, there is a high MAC, then neonates, and then adults. But in a SIVO, the sequence is first is the neonates, then infants, and then adults.
Actually, I'm sorry, I have not read about it. So, if you have read somewhere, if it
Sir,
is
actually,
universally,
yes, sir,
if
I
it
will
is
share it.
universally accepted, quote it. Otherwise, generally tell the thing which is more common. Okay. I'm not sure about it. If you can
Okay, sir.
rather, if you can share with me, I will be thankful. Okay.
Okay, sir.
Yes. What about Zishan? What's your opinion? Because I just forgot. It slipped out of my mind.
Sir,
So
I think she's right. It comes in the MCQ. This is one of the MCQ in Brown Hall, sir. So it was that there is a uniqueness to sevoflurane that it is the order is different. I read
remember
it in
one thing.
MCQ, sir.
Come out of world of MCQs. Viva is totally different. Okay. In Viva,
Yes.
they will not ask very minute details. I'm not saying you are wrong. Definitely, if you have read it, because I'm not studying. So you definitely, if you have read, it would be there. But if it is written everywhere, or it is something very common, then mention. This a common thing it's better to tell the common things. Okay. So the
Okay,
Yes,
thing
sir.
sir.
which the if you are telling, then you should be knowing uh, completely. Don't present half cooked food, so that then examiner will catch you. Okay. So these
Okay,
are the
sir.
things commonly things which we were discussing. There are chances of like congenital anomalies, respiratory. They are prone to have respiratory illness, and then another thing is that, as I told you, that they can obstruct easily. They will have, and if recent, what is the significance of recent immunization?
The child may have a fever, sir. They can have a fever or post immunization, sir.
Like immunological response. So it's better if they have recently received any immunization. It's better to delay the surgery for some time. I'm not sure about what is the recommendation for it, but it makes sense. Okay. And fasting times. What are the fasting time? 1 to 2 hours for clear fluids, 4 hours for mother feed, and 6 to 8 hours for breast. Is this like formula feed? Okay, so
Yes.
should be knowing the formulas to calculate the, yes, solid feed. Solid feed means actually, Dr. Fatima, this solid, because there is difference between breast milk and the formula feed. So formula feed takes more time. Okay. So if the patient is only on feeding, even then you will consider formula feed separately than breastfeed. So feed will be considered at 4 hours, and this formula feed is 6 hours. Okay. So this is another thing, and another point is that if clear fluids, clear juice, but if there is any juice with pulp, that will also be considered as a food. So that will also need to have around 6 hours NPU. Okay. So these are the things. What about chewing gum? Is chewing gum is related to any delay? Yes,
No,
Cerelac
sir,
mesh. Yes,
it's recommended. But sir, I don't
just reconfirm about it. Okay.
yes, sir.
So just recount about chewing gum. It just strike my mind. So and now, and if they want asking, you can say that if expertise is available, you can always measure the gastric volume. Okay. So if it is more than 0.25 ml per kg, something like that, it is like more chances of aspiration. So these are the things which, yeah, I know, actually, these are the things which are common. Any any scenario comes, whatever we are discussing right now, make a summary. Make a summary in a way that you are able to speak out in 30 seconds to 1 minute, because you will not have time more than that. Okay. Maybe we will find here. Uh, yes, it is. I think it's the same. MAC values are 3.3 in infants, 2.5 in children, and 1.7 in adult. So it is going down. Actually, I'm confused about it. I need to read about it. Otherwise, so I think this concept you should confirm it, because generally I just remember this thing that in premature, the MAC requirement will be less. Neonates, it will be less. And gradually, infant, it will be more. And then it goes down, and then it will reach the adult value. That's what I remember. Okay. And if, as we were discussing about vein finder, vein visualizer, uh, placement of tourniquets, and then this ultrasound if possible, and then intraosseous. So intraosseous line will be the last resort. Okay, you should be knowing these formulas. Uh, and actually another formula which I don't remember. If you remember, tell me how to estimate the this one uh, predicted weight according to the age. There is some formula I don't remember. Multiply by 9 or something. Just check it out. Uh, and then you should be knowing about the how to predict select the LMA, endotracheal tube, fixation of the tube. Uh, okay, so few words about analgesia techniques. So what are different various analgesia techniques? Like paracetamol is okay. Suppositories even you can give, unless there is any contraindication, you can use NSAIDs. Okay. Then local infiltration. Uh, A tap block, because tap block is a volume block. So sometimes it's difficult to give it in small babies because it will need more volume. Dilution you can do. And similarly, if you are using caudal, there is an armitage regime according to the level you want, from up to zero point 0.5 ml per kg to 1.5 ml per kg. Okay, so there is a formula for Armitage regime. You must know about it. Am I right? So that's how you calculate the doses. And this, if you, Dr. Fatima, you are who's from this physiotherapy, you must know that, like even I think there are so many techniques related to physiotherapy in which you are using not only this acupuncture, acupressure, and there is something which very simple which you can even learn, which is trigger point injections. So trigger point injections and local, you can say local infiltration will solve a lot of pain related problems. So this is also something which can be used. So, for Zishan or Umar, anyone you want to tell that if you, for example, if you have a smaller baby, so you are not able to use 0.25%, what will you do? So first of all, what you will calculate the safe dose. So safe dose will be 2 milligram per kg of bupivacaine. Okay. For example, if it is 5 kg, so 10, you can only take 10 milligram. Okay. So 10 milligram, you can only take 4 mLs. 4 mLs. Okay. So if you want to give more volume, you will dilute. So total dose should not exceed it. Okay. You know about it, Zishan and Umar?
Yes, sir. We have to Bupivacaine maximum dose is 2 mg per kg. So, in order to achieve our block, adequate level of the block, we have to dilute it so that level could be achieved and the toxic dose is not reached, sir.
Yes. So similarly, the common scenarios, we will go to the diseases inshallah tomorrow. So, but commonly, if they are asking you, sometimes there are simple questions like they are asking about this circumcision, they are asking about hernias. So the simple thing will be the answer will be very common, and you maybe need to explain all the things which we have done today, and the choice of analgesia. Okay. So ilioinguinal, iliohypogastric nerve block for this inguinal hernia, inguinal block, which we say, and wherever you are giving, you have to make sure that you don't cross the toxic dose. So these are the common things which you need to know for any pediatric patient. So inshallah, tomorrow we will do some diseases. You can have a look on some of the articles here. You will find. Okay, Zishan. So I will stop here.
Yes, sir.
Tomorrow we will do some congenital anomalies and so basic things will remain the same. Basic the anesthesia care, which will be revolving. So think about the steps of anesthesia and make your, like my request will be to make an answer, a default answer for pediatric, a default answer for elderly, a default answer for pregnant, a default answer for obese, so that these are like the 99% chances that in long case or table viva you need to explain about that. Same is true for hypertensive diabetic. Okay. Smoker. So make a very compact answer in which you cover all the changes. Okay. And changes related to anesthesia and how you are managing them. Try to tell them first. Then the rare things or extra things you can tell later on. And it is just like one, there is a trailer of a film. So if they want to ask some details, they will dig you further. Otherwise, the common things will be covered by these things, the basic things. Okay. So thank you very
Okay,
much, Zishan. Thank you very much. And please try to read this the congenital diaphragmatic hernia, infantile pyloric stenosis, some other congenital cerebral palsy. Um, uh, so we will try to cover as many as possible. Okay. So thank you very
okay,
much.
sir.
Bye
Thank you,
bye.
sir.
Thank you, sir.